Hello everyone. Good evening to all of you. Thank you. We are here we're together for the scientific sessions on metastatic breast cancer as a masterclass 2. So you all knows that the first masterclass we have started from the month of March, and we have a very good number of attendees in this masterclass. It was a record for us. Around 300 attendees was attended in this masterclass, and I am happy to inform all of you today's this event, this webinar, we have almost 500 registrations done till today morning. So with this note, today I welcome to all of you, Dr. Ganesh Bakshi sir, Dr. Amish Bora, our program director, Dr. Vijay Patil sir, all our panelists, Dr. Animesh Shah sir, Dr. Palami Basu, Dr. Sambit. So all of you, welcome to today's sessions, and we are discussing today the metastatic prostate cancer. Like last time, we have discussed on the non-metastatic prostate cancer, and I like to welcome our medical head from Samarth Oncology, Dr. Sanjay Kamble, to introduce himself and to initiate the program.
Okay, thank you, Saurav, for that kind introduction, and welcome everyone. So on behalf of the Samartha medical team, the marketing divisions and the sales team, I welcome you all again for today's program on the program that we call as a masterclass. So just to give you a background about what this is all about. So this program is started the first program in the month of March, wherein we initiated this with a good discussion on the locally advanced prostate cancer. Looking at the the huge success and on a very good discussion that we had, so we are very much glad and very much happy to announce this Masterclass 2 program, wherein it would be more scientific discussion would happen on the metastatic prostate cancer this time. And for this, we have our eminent speakers, a panel of speakers throughout the country to discuss this. So again, I welcome you all, and I request Mr. Saurav to welcome our eminent speakers and hand over the stage to them to take it ahead. Over to you, speaker. You can introduce the speaker.
Thank you, Dr. Sanjay Kamble. So actually, I just wanted to say to you that just today morning I got information from Dr. Vijay Patil sir. He is not well and he has pre-recorded his sessions. So on behalf of Dr. Vijay Patil, I would like to request and I would like to invite Dr. Ganesh Bakshi sir to initiate the sessions on observations in metastatic prostate cancer. Over to you, sir.
Thank you so much to Samarth Pharma, Dr. Sanjay Kamble and Saurav. Thanks to Vijay also. I shall go with my topic. Observation in metastatic prostate cancer. I hope we are seeing the screen, right?
Yes.
Yes, now we can see the screen. Good to go, sir.
So, observation per se in metastatic prostate cancer may be the treatment which was initiated very much in the beginning of the knowledge of the disease, probably when most patients used to, present with metastatic prostate cancer. Today, the things are very different. We have patients screening with PSA and other things for prostate cancer. And usually, observation may not be always the first line, but I'll present you some data or some things with respect to this topic. Per se, it was a very difficult topic to put forward in a forum where we have many speakers and we have so many treatments today for the setting of metastatic prostate cancer. So since mine is the first talk, prostate cancer is the second most frequent cancer diagnosis made in men. And yet the fifth leading cause of death worldwide. That is a very big figure actually. The prostate cancer incidence and mortality rates are also strongly related to the age, with the highest incidence seen in elderly men more than 65 years of age. Despite high incidence, the survival has been quite okay, or good rather, 98%. And because most of the prostate cancers which are diagnosed are slow and often indolent, men can kind of avoid immediate treatment. But in the guidelines, this is right now in the phase where we have early prostate cancer, while safely, undergoing either active surveillance or watchful waiting. So if you see current trends, and for that I have put these simple NCCN guidelines charts. So if you see the M1 disease, which is the so-called metastatic, and if you see here castration sensitive. So per se, we have one treatment which is ADT, which we have been giving since ADT was discovered in the form of bilateral orchidectomy. And then from 2015, when docetaxel, this will come in one future lecture, so I'm not talking much, but since docetaxel was used in this setting since 2015, we have furthered on to these combination therapies. Speaking on combination therapy, this is not my game today, but the whole thing which I was trying to say is ADT and combination therapy is quite a standard today. So where are we with respect to only observation? Here is the CRPC, M1 CRPC, NCCN guideline data, where again, at most places we are giving treatment to people. And if I can say so, this best supportive care is maybe, end of care treatment. So observation technically means no active treatment. In early prostate cancer, when we say active surveillance, it is active observation or active monitoring. And when we say watchful waiting, that actually means that the patient does not have to come back to the doctor with any kind of PSA or anything, unless he has some symptoms which need attention from the doctor. That's it. So as you saw in the guidelines, we don't have something which is called as a permanent observation in MCSPC, and that can happen probably in only few patients. Otherwise, the scope today for only observation is very less. So early treatment or observation, or probably I should still term it as deferred treatment. And this was maybe studied in a small set of patients. So early treatment before the onset of symptoms of metastatic disease is recommended in the majority of patients with hormone sensitive, despite lack of randomized phase 3 data in this specific setting. And there is no specific data with today combination therapies. As I said, today the data is about ADT plus some combination. So this was old data. And the only candidates with metastatic disease who may possibly be considered for deferred treatment with initial observation are asymptomatic patients with a strong wish to avoid treatment-related side effects. Or they may be really not wanting to have any treatment. The risk of developing symptoms and even dying from prostate cancer without receiving the benefit of hormone therapy with deferred treatment has been highlighted, but in the era of before the next gen imaging was used. So today, this brings question on the therapy of observation. Patients with deferred treatment for advanced prostate cancer must be amenable to a close follow-up if we put up such a patient. And another potential exception for patients with recurrent oligometastatic disease. So patients who have been treated with metastatic disease, who have a very small added on oligometastatic or oligorecurrent disease in the umbrella of oligometastasis, and who wish to postpone the treatment. Sometimes patient is doing well, it is just a oligorecurrence, things are fine, performance status is good, and in discussion with patient we can say, okay, remain under observation till things further change. And few other patients is in metastatic CRPC who have more comorbidities and cannot avail therapies, but as such are looking fine, we keep on observing them, or very rarely add one small steroid. And then there are end of treatment patients. I've seen a couple of these patients in Tata Memorial when I was working there. So these patients are the ones who have finished all lines of therapies. They are yet healthy. they are good. They come to the OPD walking, they talk nicely, eat nicely, do exercise. Somehow their cancer is progressed. They have finished quite a few of treatments, and then they remain sometimes on observation. So the other aspect, a very small aspect of observation versus treatment, but that is towards metastasis directed treatment or metastasis directed observation. So I brought this here because there were no other points and just to add an observation versus treatment kind of data. So this was presented, the STOMP and the Oriel pooled analysis in ASCO 22, examining long-term outcomes and genetic predictors of response to metastasis-directed therapy, MDT, in oligometastatic CSPC. The approach of MDT has been associated with improved patient outcomes in retrospective data and early prospective trials. A pooled phase 2 STOMP and Oriel trials to examine long-term outcomes of MDT and assess ability of a high-risk mutational signature to provide prognostic and predictive information regarding the MDT response. So if you see the chart, the graphs, giving metastasis-directed therapy has certainly improved. The HR is quite good, if you say so. Among the 116 patients included in these two trials, the median follow-up was 52.5 months. That's a very good time. And the median PFS was significantly longer for those who were treated with an MDT. So in this particular setting, at least I feel I should talk negative about observation wherever possible, wherever we can go through. I think a metastasis directed treatment is good. So that is all I think I could put together about observation, and I think most of the other speakers would highlight what is the running treatment in metastatic prostate cancer. So thank you so much. I think back to the moderator, Saurabh. Or Dr. Sanjay.
Thank you, sir. Thank you very much. So Dr. Ganesh Bakshi is a senior most uro-oncologist, and he's practicing in since long time. So thank you very much, Dr. Ganesh sir. Now I'll just go for the next speaker, Dr. and Professor Dr. Vijay Patil sir. He's senior most medical oncologist is practicing in PD Hinduja Hospital and Medical Research Center, Mumbai. So I'll request the organizer so kindly run through his presentations. He is not well today, and he informed to us that he is unable to join today. And so we are running his pre-recorded video here. So what to my ideas? Kindly help us to run this video, please. Thank you.
Good evening, and I'm sorry that I'm not there physically, and I had to send this recording. So today we'll be talking about systemic therapy in metastatic prostate cancer, and my job will be to talk on castration-sensitive prostate cancer. Now, we must understand that when we talk about prostate cancer, what helps it to grow is testosterone. So this is one of the first kind of targeted therapy where you remove the testosterone source and the cancer would get into control. So androgen deprivation therapy remains the backbone of castration-sensitive prostate cancer management. It can be via surgical occludectomy or it can be via medical castration, in which you can use either GnRH agonist or you can use GnRH antagonist. GnRH antagonists are easy to understand. You're antagonizing it so the GnRH doesn't get released. What does GnRH agonist does is, if there's a continuous stimulation of the hypothalamus by a GnRH agonist, it leads to a negative feedback. And initially there is a rise of GnRH, but then it stops. We must also understand that this GnRH agonists, which are synthetically made, are difficult to destroy by the body enzymes and have a long and better affinity to the receptors. Now, what happens when you give androgen deprivation? You would see a response in 80 to 90%. You will have a PSA normalization in greater than 90% of the patients, and yes, there is improvement in quality of life. It also decreases the chances of vein pains and other complication rates. Now, which ADT we would give? Whether you want to give a GnRH agonist, yeah, as I told you, it's synthetic, they have a high receptor affinity, low degradation rates, they're 100 times more potent than the naturally occurring one. Now, what happens is when you administer them, there's an initial rise in testosterone, and after 1 week, there's a downgrading of the GnRH receptors. After 3 to 4 weeks, you see a decrease in testosterone level, and it is reversible. So, if you stop the GnRH agonist, the testosterone will come back. There are this LGBT, this is leuprolide, goserelin, bosulinol, and tryptolin, which are the formulations which are available. You can use them at 1 month, 3 months, or 6 months. The target is to get the testosterone level below 50 nanogram per TL or 1.7 nanomole per liter. Understand that because of the initial rise in testosterone, you may get a flare phenomena. So you would like to use bicretide or peripheral androgen blocker during that. Now, let's look at the that whether you want to do orchiectomy or you want to do GnRH agonist. Now, when you look at this meta-analysis, which was published in 2000, both have similar efficiency. There is no difference whether you want to use GnRH agonist or surgical occurring. So it boils down to the efficacy. It doesn't boil down to the efficacy. It boils down to the personal choices of both the treating physician and the patients. Now, what about Degarelix? And we have comparative study of Degarelix in prostate cancer. And what we see is that the suppression of testosterone is achieved with a higher level in patients who receive Degarelix. Now, what we must understand, it is not achieved in all 100%. So, if your patient is not benefiting on Degarelix, if it's complaining of pain on Degarelix or on even leuprolide, it's better that you check the testosterone levels. The median PSA levels at day 14 and day 28 are more significantly lower in Degarelix than in the leuprolide group. The side effects of Degarelix are similar to that for androgen deprivation therapy, that both the side effects are same. You don't get a flare phenomena. However, because this injection is subcutaneous and needs to be given every monthly, as opposed to the IM leuprolide injection, the injection side reactions are more with Degarelix. Now we have randomized studies, and there are more than one comparative to suggest that the efficacies are similar. So you can choose any one of them. Many times it has been said that probably GnRH antagonists can lead to lesser amount of cardiovascular events, but there are papers to refute that claim also. But it makes more sense that if patient has previous cardiovascular event to use Degarelix and not leuprolide or triptolin. Now, when do you want to start EDT? You found a castration-sensitive prostate cancer. Do you want to wait or you want to start immediately? And this also has been seen that if you start early or late, it's clear that an early start of androgen deprivation therapy improves overall survival, improves disease-free survival, decreases the skeletal events, decreases the adverse events also, and improves the global quality of life. So, start early. How long? Now, understand that the duration of androgen deprivation therapy is continuous while in the CSPC phase, also in the CRPC phase, so it doesn't stop. The question is, do you want to give it continuous or do you want to use intermittent? Because androgen deprivation therapy is associated with side effects, recommendations for intermittent use have been provided. Now, why this recommendation show that it leads to decreased adverse events and improves quality of life, and also there's a theoretical possibility that it can delay the progression by inhibiting mechanisms which led to androgen independence dependence. How it is done? You start with androgen deprivation therapy for 4 to 6 months. You get a maximal response. After that, you withdraw the androgen deprivation therapy and keep testing for the PSA. You have a set parameters, let's say the 10 nanogram per ml or 20 nanogram per ml of a PSA benchmark, above which if it happens, then you would restart the androgen deprivation therapy. Do we have studies to say that intermittent versus continuous? We have this New England Journal of Medicine trial, which actually shows that intermittent failed to achieve non-inferiority. The surprising part was, except 9 months and 3 months erectile dysfunctions, the side effects also were very similar. However, there has been a renewed interest in intermittent androgen deprivation. EORTC wants to run a large pragmatic study to see whether this can be done, as it can bring down the cost and probably decrease the side effects also. Now, when do you start androgen deprivation therapy, and whether this can be done in patients who are locally advanced disease. This is not the topic today, but there was this randomized study and it did show that it did prove non-inferiority of intermittent androgen deprivation. But we must understand that only 11% of patients had metastatic disease, and this data is more applicable for locally advanced patients. I won't talk more on preventing side effects of androgen deprivation because Dr. Nandini is going to talk on that. Now, in today's world, do we only give androgen deprivation in CSPC or we add something else? Now we have data for adding docetaxel, and there are variable number of studies which have been done for addition of docetaxel with androgen deprivation therapy, and variable number of cycles from 6 to 9, and in some 6 to 9 it has been done. And these are the three common studies: GOTEC study, the Charted study, and the Stampede study. What each of these studies did show that there was a unanimous benefit of adding docetaxel to androgen deprivation therapy. And when we look at this benefit in terms of multiple things like for overall survival, the impact is moderate. On prostate cancer specific, that it's moderate. Progression-free survival, it's moderate. Obviously, addition of a therapy leads to adverse events, and that was seen in these patients also. Now, do we add docetaxel to all patients? Let's see what the studies did. Stampede, de novo metastatic disease, all were included. So you can actually start in all patients. Charted included patients which were called high risk, that is 4 or more bone mets, or patients who are visceral metastasis. Latitude, Gleason of 8, 3 bone lesions or more, or presence of visceral metastasis. So you could see that there is a differential criteria which are used by different people. Many people would prefer to be used in high risk, like Gleason is more, bone lesions are more, visceral mets are there. And each of the studies that show that there is a benefit in overall survival. The question is, okay, androgen deprivation therapy plus docetaxel, can we improve it more? And let's look at this data from PEACE, in which prostate cancer patients who were castration sensitive were randomized to abiraterone or radiotherapy, and this was a 2:2 factorial design. Now, what's interesting is when the study recruited, it's a very pragmatic study, and the study recruited, it had multiple number of standard of care, and for a long time the standard of care was androgen deprivation therapy plus docetaxel, thus giving us a chance of comparison of ADT plus docetaxel versus ADT plus docetaxel plus abiraterone. Let's look at the value of this, and what we see is that when abiraterone is added, there's nearly doubling of the progression-free survival from 2.2 years to 4.5 years, and also this led to an impact and improvement of around 2 years in overall survival. To today's world, you will want to add androgen deprivation therapy plus docetaxel plus abiraterone in these patients. If you look at this data, this becomes more clear. With androgen deprivation therapy, you have median survivals in the range of 30 months. With docetaxel in the range of 40 months. When you add all three together, in the range of around 60 months. This therapies are toxic, but then you need to take care of the toxicities in these patients. Is abiraterone the only option? No, Enzamet gives a similar study for enzalutamide also, where you could see that there is an improvement in survival around 10% in this patient in which enzalutamide was used. Again, we could see that abiraterone leads to more cardiac side effects, enzalutamide leads to more memory disturbances. So I would be using enzalutamide in patients who have cardiac issues, and abiraterone in patients who have neurological issues. What about daralutamide? You could see that you can add daralutamide also. You could see that the overall survival in the tune of around 10% was increased with the addition of daralutamide also, and not major increase in because of side effects. Now understand, prostate cancer patients are elderly, so you need to have fitness parameters which are there, and comprehensive geriatric assessments help. And comprehensive geriatric assessments are best done in a comprehensive geriatric care clinic with spending around 2 to 3 hours with the patient, which can help you to tailor your therapies accordingly. So my algorithm is in the practice is, if I see a CSPC today, if we do a CGA in this patient, if it's elderly and it is negative, which means patient is fit, whether it's high or low volume, I would go with the 3-drug therapy. If the CGA is vulnerable, then I would go over an ADT plus therapy. And if the CG is fail, I will go with an EDT alone. With that, I would like to say thank you. Response assessment is done every 3 monthly, and bone modifying agents in CSP.
Yeah, sir. So, Saurabh, over to you to invite the other.
Yeah. Kindly open the slide for Dr. Arun Chandrasekharan. So we are very happy and we are extremely, it is our pleasure to have Dr. Arun Chandrasekharan as a speaker for the castration-resistant prostate cancer. How do I treat today? So he is a consultant oncologist, and he is from the Department of Medical Oncology from Aster Mims Hospital, Calicut. So thank you, Dr. Vijay Patil sir, for your presentations. Though you are not there today, but yes, your slide and your presentation is very informative. So now I will welcome Dr. Arun Chandrasekharan sir. So kindly spend some time for your informative presentations. Thank you.
Oh, thank you. Is it okay if I share the slides from my side? Yeah.
Yeah, please, sir.
Okay. Oh, 1 second. Okay. Oh, 1 second. I think I accidentally closed it. Yeah. Just give me. Okay. So thank you to Samarth Oncology for this opportunity. And yeah, I've been keeping unwell for the last 1 week. So I had taken the help of Dr. Alok Gupta, has already made these slides, modified it slightly a little bit. So forgive me if the presentation is not perfect. I didn't get time to, practice. I've been on bed rest for the last 1 week. Okay. So my topic of discussion is castrate-resistant prostate cancer. How do I treat it today? So, 1 second. So, we've already covered the castrate-sensitive prostate cancer, and I think that's where most of the changes or most of the developments which have happened in that space, where you have the maximum survival benefit in patients. So when we talk about castrate resistance, you have to discuss two parts. One is the non-metastatic castrate resistance and metastatic castrate resistance. So non-metastatic castrate resistant prostate cancer is where you have a rising PSA in spite of ADT. And when you do conventional imaging, you do not find any metastasis anywhere. Now, in the era of the PSMA PET, this kind of presentation is rare but not unknown. So if you have a patient who's got no metastasis but PSA is rising in spite of ADT, you look at the PSA doubling time, and if it is less than 10 months, you have 3 drugs, which is apalutamide, darolutamide, or enzalutamide, which have been approved. So the 3 drugs have 3 trials: the Aramis for darolutamide, Spartan for apalutamide, and Prosper for enzalutamide. And all of them have shown an improvement in the metastasis-free survival with quite significant hazard ratios. There is also overall survival benefit with all 3 drugs. So it has been approved. It is approved by the FDA, as well as it's available in India. The overall survival hazard ratios range from 0.69 to 0.73. So starting these hormonal drugs early does improve overall survival. The only way to choose between these 3 drugs is to look at the toxicity profile, where darolutamide is the least toxic because it does not cross the blood-brain barrier. Moving on to metastatic castrate-resistant prostate cancer, because if you have multiple sites of metastasis, things are much more well-defined. So you have multiple agents which are FDA approved as of now. You have Sipuleucel, T, Abiraterone, enzalutamide, Dosi, Cabazi, radium-223, and also lutetium therapy also, which got recently approved. So of these, radium and Ciprucil T are not available, and I've got no personal experience using it. But the other drugs are definitely available. You have the survival benefit ranging from 2.4 months to 4.1 months. So in the castrate resistant setting, what you can see is that the absolute benefit is not as much. Your best chance of treating prostate cancer is when it's castrate sensitive. So this again shows you the available treatment options in castrate-resistant prostate cancer. You have newer targeted therapy agents like pembrolizumab and olaparib as well. And you have non-FDA approved therapies like platinum. We do use carboplatin in certain subset of patients, especially those with neuroendocrine differentiation or those who've got some form of HRR mutations. Also, Hornvan or phosphistrol has been used off-label in management of these patients as well. So what we're going to cover is the first line, what we use in second line, and is there any particular sequence and of sequencing these various agents and the role of targeted therapy and immunotherapy. So you to decide on which is your first line, you have to see what the patient was receiving in the castrate sensitive phase. So if the patient is receiving ADT alone and then progresses to castrate resistance, you have options of DOSI, abiraterone, or enzalutamide. Now, if a patient has already received DOSI or already received abiraterone or enza in the upfront setting, then you still have these options, but there is no real, some of them have phase 3 trials, but there's no real phase 3 data telling you what exactly to do. So we'll take an example of a 62-year-old male who had a CA prostate diagnosed in March 2018, stage 4 disease, initially started on ADT alone, and within the same year, he started progressing with a rise in PSA. On scan, that showed multiple bony mets. So this patient received ADT alone and has developed castrate resistance right now. So what next in this patient? So the data for this, you have the usage of docetaxel, which 2 trials, the TAX327 and the SWAB trial, showed overall survival benefit, which can be seen in this curve. It's not much, it's around 2.5 months, but 3-weekly docetaxel was better than weekly docetaxel and mitoxantrone. So this was the TANOC trial, which established docetaxel in the castrate-resistant setting. So let's take another example of an 88-year-old male who again was diagnosed with a metastatic stage 4 prostate cancer and initially started on ADT therapy alone. After ADT therapy, 1 year later, PSA starts rising and he develops castrate resistance. PET shows multiple lesions. Now, the problem is this patient has multiple comorbidities. PSS2, age is 88 years old, and he's having heart failure and NYHA grade 2 heart failure, which is there. So you've got cardiac issues, you've got diabetes, and you've got a poor PS. In such a patient, using docetaxel is definitely a challenge. And in this patient, you have an option of abiraterone or enzalutamide. And in this case, enzalutamide will be preferred because abiraterone is contraindicated in patients who've got heart failure. And also, since you use steroids along with abiraterone, you have to be a little careful. So the PREVAIL trial was the one that showed enzalutamide if efficacy in patients who have metastatic castrate-resistant prostate cancer. Enzalutamide was compared to placebo in patients who were chemotherapy naive, and the primary endpoint was overall survival and radiographic PFS. And you can see here the median overall survival was improved with enzalutamide, 32 months versus 30 months, and also significant median radiographic progression-free survival. So, and there is data to use enzalutamide in the upfront castrate-resistant prostate cancer. What about abiraterone? If this patient was much fitter with no heart failure, we could have used abiraterone. You have the COUAA 302 trial, where again they took chemo-naive castrate-resistant prostate cancers and randomized them to abi versus placebo. And abiraterone showed a significant survival benefit with the updated analysis showing a benefit of 35.3 versus 30 months. So 5-month benefit in the castrate-resistant setting. Now, moving on to the second line treatment for castrate-resistant prostate cancer. So going back to the first case, the patient who received docetaxel in the castrate-resistant setting, after some time, he again developed the progression in PSA and uh, increase in the disease. In this case, what would be the next option? So there is an option of cabazitaxel, abiraterone, or enzalutamide. So cabazitaxel's benefit was proven in the TROPIC trial, where they gave cabazitaxel and compared it to mitoxantrone in patients who had already received docetaxel. And the overall survival benefit was 15 versus 12.7 months, with a significant hazard ratio 0.70. So 30% decrease in the risk of death. Abiraterone also has been studied, the 301 trial, where they give abiraterone in patients who have already completed docetaxel. And in this case also, abiraterone showed a benefit of 14.8 months versus 10.9 months. The AFFIRM trial is the trial which looked at enzalutamide. And then this also enzalutamide after the usage of docetaxel when compared to placebo showed an 18.4 months versus 13.6 months benefit, hazard ratio 0.63. So all three of these molecules have shown overall survival benefit. Now, if you look at this second case in the patient who received enzalutamide, the old patient who had castrate-resistant prostate cancer because of his heart failure, we gave enzalutamide. And after enzalutamide, 6 months later, he developed progression. In this case, what would you do? Would you consider chemotherapy versus androgen receptor-based therapy? Now, again, chemotherapy in this age and this kind of heart failure would be difficult, and most probably you would not do it. But supposing this patient was healthy, is there a correct sequence? Should you use chemo after usage of an androgen receptor blocker, or should you use another different kind of androgen receptor blocker? So you have data which has looked at the sequencing, and what it found out is that if you use enzalutamide after abiraterone, means enzalutamide after abiraterone or abiraterone after enzalutamide, overall outcomes are poor. Now, the sequence of enza followed by abiraterone is slightly worse. When you give enzalutamide first, and then after that you give abiraterone, the PSA drops are less than 10%. But when you sequence abiraterone followed by enzalutamide, you get slightly better 30%. But overall, the benefits are not as great as when you sequence chemotherapy after an androgen receptor blocker. So this systematic review analysis looks and tells us that the 12-month OS rate after docetaxel, when you use after docetaxel, cabazitaxel, and then androgen receptor therapy, or you use androgen receptor therapy followed by cabazitaxel, the overall survival is much better than when you sequence two androgen receptor therapies together. So if you have an option in a patient who's already received enza or abiraterone, moving to chemotherapy, either cabazitaxel, or if there's a long time since they've received docetaxel, going back to docetaxel is still a decent option. What about targeted therapy? So in targeted therapy, you have lutetium-177 PSMA therapy, which is being used widely now. The data from this comes largely from the VISION trial, which was conducted in, I believe, Europe, North America. And in this, they took patients with metastatic castrate-resistant prostate cancer who already received one androgen receptor inhibitor and 1 or 2 taxane regimens, and randomized them to receive a standard of care plus PSMA therapy versus standard of care. A standard of care had to exclude chemotherapy, immunotherapy, radium, or other investigational drugs. Mostly it was ABI, ENZA, other hormonal therapies, and patients were followed up. Lutetium therapy was given every 6 weeks for 4 cycles, and you could give it maximum up to 6 cycles. So the primary analysis showed that there was a prolongation in overall survival, hazard ratio of 0.62, median survival of 15 versus 11 months. So this therapy has been FDA approved and is being used in centers where they have it. The other targeted therapies which have been studied is one is the homologous recombination deficiency or the genomic instability which is there in certain patients of prostate cancer, and the presence of MSI high or microsatellite instability. So DNA structural damage, especially double-stranded breakage, is repaired by homologous recombination repair. And in patients who have this problems with this set of genes, you can target them using PARP inhibitors like olaparib or rucaparib. Prostate cancer, around 12% have germline mutations in this DNA repair process, and almost 25% have a germline or somatic mutation. So 25% of your prostate cancer patients can be targeted by this drug, by PARP inhibitors. BRCA2 is the most common mutation seen in these patients with these DNA repair defects. So the trial which tested the usage of olaparib was the PROfound trial, and the PROfound trial took patients who had prior received abiraterone or enzalutamide and not received prior chemotherapy, and split them into two cohorts, one cohort having a BRCA2 or a ATM mutation versus cohort B, which had the other mutations which were there. So they randomized them to olaparib versus physician's choice, and they were followed up. The primary endpoint was radiographic progression-free survival, and this radiographic progression-free survival was significantly better in the whole cohort of A plus B as well as cohort A, which was BRCA1, 2, and ATM gene. The difference was 7 versus 3 months in the cohort A versus 5 versus 3 months in the combined cohort. So based on this data, this drug was approved, but there are a lot of skeptics and a lot of issues with this trial. There are a lot of seminars on how not to conduct a clinical trial using the PROfound data, because they actually did not give a standard control arm over here, and patients did not receive chemotherapy in the majority of the cases. So we were actually undertreating the control arm. So this is something which we have to look at with a little bit of critical eye. The MMR mutations or the MSI high is the other targetable area in prostate cancer. However, you have very less percentages. You have 2% MMR mutations or 2.7% where only MSI high. And you have data from Keynote where tumor agnostic, you can use pembrolizumab in patients who are MSI high. In that trial, I think there's one patient with prostate cancer, and it showed decent responses in them. So if you look at the current NCCN guidelines, you have all these drugs which are there in the castrate-resistant metastatic prostate cancer group. We've covered most of them. I've not covered radium or Sipuleucel-T because they're not available. Rucaparib is also entered the guidelines, which can be used for BRCA mutation. For HRR mutations, olaparib is the current recommendation. The final take-home message is when you have metastatic castrate-resistant prostate cancer, first ask what the patient has received in the sensitive setting. If he's received ADT alone, then you can move ahead with docetaxel, especially if you have visceral mets, or you can consider AB or Enza depending on if the patient has very mild symptoms or low volume of disease, and you want to avoid side effects of chemotherapy. Avoid Enza in patients with seizure disorder. Avoid abiraterone in patients with heart failure or uncontrolled diabetes. If the patient has received chemo plus ADT, you can move on to another androgen receptor blocker like abiraterone, cabazitaxel, or even enzalutamide. And if it's abiraterone has been used with ADT initially, then using chemotherapy like dosi or cabazi is better than going to enzalutamide. So avoid using back-to-back drugs of like EV plus enzalutamide, ART followed by ART. And if you've been exposed to chemo and androgen receptor therapy, lutetium therapy with PSMA, lutetium PSMA therapy is definitely an option. And the sequence of chemo followed by ART, followed by cabazitaxel, followed by ART probably should give you the best survival outcomes. You can also add lutetium therapy. Don't forget to test for MSI and HRR as well. HRR, it's a personal opinion. If you want to use it, you can do it. And the genomic, you have rucaparib, which is also approved. So as per the NCCN guidelines, all metastatic prostate cancers can currently be tested for HRR mutations. I think that's the last slide. Thank you for your patience.
Thank you, Dr. And it was an excellent talk. I think just for an interaction, Dr. Amish Vora has sent a chat box. I don't know for which patient he meant for. If Dr. Amish Vora sir is there, kindly please. Yeah, thank you, sir. So I can found one chat box that one of the patient who has progressed very fast. So he has asked,
No.
will
So yeah. I think Dr. Arun, first of all, very crisp talk. Pura revise ho gaya. Thank you so much for that. And I just wanted to say that patients, there are two types of patients, ART, and normally we are talking of de novo metastatic. There are two types of patients, one who progress on ART after a long time and one who progress within 10 months.
Yeah.
So I think there the sequence probably, if my this thing, I'll make our ARV7 if we do, and if ARV7 is negative, and if ART has worked beyond 10 months or 12 months, probably you can give a second line,
sequence,
a second generation anti-androgen. But as I said, you have covered the things extremely well. Thank you so much for that.
Yeah. Thank you, sir, for coming.
Saurav, you are muted.
Okay, so thank you both of you for the nice interactions, and we got a clear picture about that when the second line of anti-androgen has to be come across. And now we'll go for the the next topic, the radiation in metastatic prostate cancer, when, where, and how. So I'd like to welcome Dr. Moses. He's a consultant radiation oncologist, and he's in practicing in Tata Medical Center, Kolkata. So kindly run this.
Good evening, everyone, and thank you for inviting me for this exciting meeting and for giving me the opportunity to talk on the role of radiation in metastatic prostate cancer and the evidence behind when to do it, where to do it, and how to do it. So moving right into the talk, I've split my talk into two broad sections. One is the prostate-directed radiotherapy, where we have much strong evidences. And the second part of the talk, we will touch upon metastasis-directed radiotherapy as well. So what could be the rationale for targeting the prostate alone when the disease has already spread elsewhere out of the prostate and out of the pelvis? So one could be that by targeting the primary, we are able to prevent a second wave of metastasis from happening. And also, it is possible that the proliferation of metastatic cells are dependent on compounds that are secreted by the primary tumor. That is, the metastatic cells are still under the control of the primary tumor. So, but by ablating the primary tumors, we are able to exert more control on how the metastasis progresses further. So, but what is the evidence that is there for doing these things? So there have been several retrospective reports, and this is one such large report from the National Cancer Database in the US. It was a propensity score matched analysis of those who received prostate-directed therapy versus those who didn't receive prostate-directed therapy for metastatic prostate cancer. And what it showed was there was an improved 3-year overall mortality-free survival to the tune of nearly 15%. And what they also saw was that the benefit reduces with the increasing the risk due to comorbidities that may be present in the patient. But we need randomized evidence for us to consider prostate radiotherapy as a level 1 evidence, and that is what was done in this setting. So first trial that tried out this was the HORAD trial. So what they did in the HORAD trial was it was a fairly large trial with 432 patients with baseline PSA of more than 20, and there had to be bone metastasis on bone scan. So these patients were randomized to androgen deprivation therapy alone, which is the standard of care, versus receiving local radiotherapy in conventional fractionation or a slightly hypofractionated, moderate hypofractionated radiotherapy targeting the prostate. So the median PSA of this group of patients who were randomized to this trial was 142, and 67% of the patients had more than 5 osseous metastases. So what this trial showed was that there was no difference in the overall survival between the two arms. It was 45 months in the RT arm, and in the control arm, it was just in the similar ranges at 43 months. And when they looked at multiple subgroups based on the number of bony metastases, there was no clear benefit seen in any specific group, regardless of how you classified it. But there was a trend which showed that there was a possible benefit in those with less than 5 metastases. So then there was another trial from the UK. This is the Stampede trial, which has been churning out results after results for prostate cancer. In one of the arms, they also tested the possibility of giving prostate-directed radiotherapy in metastatic prostate cancers. And this was a much, much larger trial as compared to the HORAD trial, with nearly 5 times the number of patients here, with more than 2,000 patients being randomized to ADT alone, plus minus docetaxel. I think about 20% of patients received docetaxel in the standard arm, and in the control in the test arm, they had an addition of local radiotherapy targeting the prostate alone with either a moderate hypofractionation or an SBRT fractionation as well, being allowed, being delivered once in a week. What this trial showed in the overall setting was that there was no difference in the overall survival. The two arms had 46 and 48 months respectively. But what it showed was there was an improved failure-free survival with the addition of radiotherapy targeting the prostate. And this was nearly 9% improvement with the addition of radiotherapy at 3 years. So on the basis of these two trials, we can conclude that overall there is no role of local radiotherapy for metastatic prostate cancers. But the caveat is that it is in an unselected population of metastatic prostate cancers. There is no role of local radiotherapy. The Stampede trial looked at a subgroup analysis of classifying patients between low burden versus high burden. The way they classified this high metastatic burden versus low metastatic burden was using the charted trial definition. Mind you, charted trial was a trial which was designed to look at systemic therapy for prostate cancer. And this trial had a definition of high volume versus low volume metastatic burden. And this definition was applied to classifying the burden of metastatic disease in Stampede trial as well. And this is the definition that most of you are familiar with. And what this subgroup analysis showed was that in addition to RT improving the failure-free survival, there was also an overall survival benefit to the tune of nearly 8% at 3 years. There was a further stopgap meta-analysis putting together all the patients from HORAD and Stampede. There were 969 deaths as events. And in an unselected population, there was a definite 3-year biochemical progression-free survival and failure-free survival improvement by about 10%. And in those with low burden metastatic disease classified as less than 5 bone metastasis, there was an absolute improvement of 7% in 3-year overall survival. So there is definitely a survival benefit for the addition of local radiotherapy targeting the prostate in a selected population of metastatic prostate cancers with limited metastatic burden. But how do we select or define low metastatic burden? Different trials have done it differently. So how many bone metastases and which bones there are So like we saw in the Stampede trial, they have used the metastatic burden as defined in the Chartered trial, but there have been secondary analysis done which looked at just the number of metastases alone, and what they found was that if you had less than or equal to 3 bone metastases, then there was a benefit regardless of where that metastasis was located at. And there was also suggestions that from retrospective studies that if you had bone metastasis primarily situated in the vertebral column alone, then they may do better with the addition of prostate-directed radiotherapy. But unfortunately, in the Stampede trial, such patients were only less than 2%. So we are left with a complicated definition of what could be the low volume metastatic disease, which would benefit from the addition of prostatic radiotherapy. So what was done in the trials that have examined this, we can look at it. The number of mode metastases have been defined differently in the 2 trials. I think it's better to stick with the trial which was positive and say that a Chartered trial definition or the secondary analysis definition from the Stampede is a good enough definition. And also the imaging modality matters. We know that if you use a more sensitive imaging modality, you will be better at picking up metastatic disease, but all you maybe end up doing is migrating the patients into a different group and end up creating Will Rogers phenomenon. So that is what is possibly happening with the new uptake of PSMA staging for most of our patients. And so this is a kind of chart which looks at the different sensitivities and specificities of different imaging modalities we have for identifying metastasis in prostate cancer. I was about to say that in the HORA trial, they looked just at the bone metastasis alone, whereas the Stampede trial possibly was a much more stringent criteria of eliminating visceral metastasis as well, and that is why they were able to possibly pick up a benefit as well. And is it just about looking at the number of metastases? What about all the different biological factors? And if you put together all of that, I think we will be ending up with much more confusion like this one, where we have different terminologies for different combinations of areas in the United Kingdom region. And that is what was observed in the different trials as well. If you look at the definition of low volume metastatic disease as such simply, there are different impact of that as well, because if you say that the number of metastases in the vertebral column doesn't matter in the definition that we have as of now, and what about those who have only non-regional lymph nodes? All of these are not very clear from the definition that we have as of now. And what about the impact of systemic therapy? From what was done in the Stampede trial with ADT alone for most of the patients, we have moved on to combination treatment for a majority of our patients in the first line. And what is going to happen to these patients if we add prostate radiotherapy is something that we don't have clear answers for. And my conclusion is that there is a role for prostate radiotherapy in low volume metastatic disease. Whether you use the Chartered definition or the HORA definition, it's up to you. But there are several questions which remain to be answered. Whom do we treat, and what is the definition? What imaging modality? What will be the impact of newer imaging modalities? What is the impact of newer systemic therapies? And what should be the timing of radiotherapy? Should we wait for the ADT to start working before we offer radiotherapy? Is there an effect for dose of radiation? And what if we can combine this with metastasis-directed radiotherapy as well? Will that improve the outcomes? These are all questions that remain to be answered. And some of these will be answered in the PEACE-1 study. The systemic part of it has been reported, but the radiotherapy part of it is, I think it's still ongoing, and this will add more value to our discussions in the future. And there's also a planned stopgap meta-analysis as well once these results are out. Moving on to the second section, that is metastasis-directed radiotherapy. Is there a rationale to target all the metastatic sites? What could be the rationale for it? So it could be that we are able to prevent further progression, and also it may help in delaying the initiation of further treatment. Saber Comet, most of you are well aware of this. This is not a prostate-only trial. This was a site-agnostic study, standard of care alone versus Saber to all the visible lesions. And what it showed was there was a significant improvement in overall survival at 5 years, and a considerable number of prostate cancer patients were treated in that study. But the prostate specific studies are STOMP and ORIEL, and that is what I'm going to touch upon here. In the STOMP study, they looked at 62 patients. These were all phase 2 studies, 62 patients with biochemical recurrence who were found to have less than or equal to 3 metastases on PET scans with proven non-castrate levels of testosterone. They were randomized to surveillance versus metastasis-directed radiotherapy. The primary endpoint was, of course, delay in the initiation of further treatment. And what it showed was the addition of radiotherapy to the metastatic sites definitely delayed the initiation of ADT for these patients. And the 5-year ADT survival, ADT-free survival was significantly higher in the MDT arm. And there were similar results seen with the ORIOL trial as well. Here, again, asymptomatic oligometastatic patients who had less than or equal to 3 mets on PET scan and who had not received any ADT for the past 6 months were randomized to, again, surveillance versus Saber to the metastatic sites. And the primary endpoint was progression-free survival. Again, you can see that the 6 months progression-free survival and the median PFS were significantly improved with the addition of metastasis-directed radiotherapy to all the metastatic disease. I think with that, I come to the conclusion of my talk on role of radiotherapy in metastatic prostate cancers, and I have shown that there is definitely a role for targeting the prostate alone in low-volume metastatic disease, and there is upcoming emerging role for targeting the metastatic sites with an aim to delay further initiation of treatment. With that, I thank the organizers again for inviting me to this talk and enabling me to be part of this esteemed meeting. Thank you.
Such a beautiful talk and excellent effort by Dr. Moses. I really appreciate on behalf of the entire attendees and the faculties. Dear Dr. Moses, it's a great effort. Your presentation was nice and it was very crisp. So now next we'll go forward for our next sessions. I will welcome Dr. Rohit Pai, the consultant medical oncologist practicing at Bombay Hospital Medical Research Center, Mumbai. So he's going to talk on PRP inhibitors in prostate cancer. Over to him. Thank you.
Thank you to the organizers for the invitation. Thanks everyone for attending. Can someone please load my presentation and have it the bit. Thank you. Thank you. Am I audible?
Yes, sir. You are audible, sir.
Yes, I would like to start now. So today I will be talking about PARP inhibitors in prostate cancer. Next slide, please. So genetic testing is the standard of care in prostate cancer, and now we offer testing to all patients with metastatic prostate cancer. Mutations may be germline, so basically a blood test or sometimes a saliva test, or in the tumor itself. So these are the somatic mutations. And somatic DNA testing may change over time due to genetic instability of tumor DNA, various treatments which are given. And sometimes you may consider serial tumor or liquid biopsies. Now, overall, 23% of metastatic castrate-resistant prostate cancers have DNA repair alteration. 11.8% in one case series of 692 men had germline DNA repair defects. What are these defects? So the most common gene involved, so the genetic mutation which is involved in prostate cancer, especially the germline mutations or the somatic mutations, is BRCA2. So you can see here in the pie diagram, 44%. The others are ATM, BRCA1, CHEK2, etc. And there are other DNA repair genes like PALB2, ATR, etc. Also, prostate cancer is one of the cancers which is associated with defects in the mismatch repair genes. And prostate cancer may be seen in Lynch syndrome also. So MSH2, MSH6, etc. also may be altered. But essentially, these DNA repair defects are potentially actionable mutations. So if you are having a defect in the HRR pathway, homologous recombination repair pathway, you can treat with PARP inhibitors. If you have an alteration in the mismatch repair pathway, potentially immunotherapy is an option with pembrolizumab in subsequent lines of treatment, especially because there is a site agnostic approval for use of pembrolizumab in such patients. Next slide, please. NCCN recommendations: those with a positive family history of cancer, breast, ovarian, pancreatic, prostate, colon cancer, endometrial cancer, regardless of the stage of the disease, should be tested. Patients with known DNA repair mutations, DNA damage repair mutations in the family, like I just mentioned, BRCA2 mutations or history of Lynch type of syndrome, should be tested. Those with a personal history of prostate cancer with the following features. So high risk localized also should be tested. Node positive should be tested. Metastatic all should be tested. And in men with ductal or intraductal histology, we can consider germline mutation testing with prostate cancer. Next slide, please. Mutations are available from the primary prostatic biopsy or a radical prostatectomy specimen or metastatic tissue biopsy. Also, liquid-based biopsy, even HRR deficiency or HRR gene testing in cell-free DNA or circulating tumor DNA or circulating tumor cells is coming up. Liquid blood-based biopsy is simple, convenient, and can also track the evolution of tumor, because with subsequent treatments, you can develop additional mutations. Also, in the upcoming trials of PARP inhibitors, most of them have used, many of them have mainly used a liquid-based biopsy assay to sort of determine HRR status. Nowadays, the issue with tissue-based testing for HRR is sometimes the sample is too old. The prostate cancer, the prostatic biopsy has been done a couple of years or 3 years back, and now you are going to test. The patient is reluctant for a repeat biopsy, so as to speak, or the issue is that the site of the metastasis, etc., is not very accessible. So liquid biopsy-based testing, even for HRR, is one thing which is coming up. Next slide. So PROFOUND study is the main study which demonstrated benefit of PARP inhibitors in the CRPC setting. So in PROFOUND study, patients with metastatic castrate-resistant prostate cancer were stratified according to the previous use of taxane and measurable disease. There were two groups. There were two cohorts. Cohort A, so all of them had alterations in the HRR gene. So the list is there in the red. So BRCA1, 2, ATM, BARD1, CDK12, CHEK1, etc. So there is a long list. Everyone had an alteration in the gene, but these patients were divided into two cohorts. Cohort A was BRCA1, BRCA2, and ATM. So that is potentially the most common alteration you expect. BRCA2 is the most common, followed by ATM, followed by BRCA1. And 245 patients of cohort A were then randomized in a 2:1 fashion to olaparib 300 milligram twice a day, that is the standard dose, versus physician's choice treatment. And in physician's choice treatment, important to know is you have enzalutamide or abiraterone acetate. So patients who were on enzalutamide, who were having a prior progressive disease on one androgen-directed therapy, were included. Those who were on enzalutamide were given abiraterone. Those who were on abiraterone were given enzalutamide. And there was another cohort B with similar randomization with all the other alterations. So the non-BRCA1, BRCA2, and ATM alteration, and they were divided in a similar manner. Essentially, the inclusion criteria was HRR gene mutation in this long list of genes and progression on prior newer hormonal treatment. So either enzalutamide or abiraterone. There was sort of one of the questions raised was the chemotherapy was not included in physician's choice. Okay, so standard chemotherapy was not included in the physician's choice. It was only anti-androgens, and we know that there is an issue that when you use one anti-androgen, the subsequent anti-androgen does not sort of work that well. Okay, primary endpoint was radiographic progression-free survival in cohort A using the RECIST criteria and the prostate cancer working group criteria. And secondary endpoint was PFS in both the cohorts. So confirmed radiological response, overall response rate, time to pain progression, and overall survival in cohort A. Next slide, please. Essentially, what is important is the study met its primary endpoint. So, in patients in metastatic castrate-resistant prostate cancer who progressed on abiraterone or enzalutamide and had an alteration in one of those 15 pre-specified genes in the overall population, there was improvement in the radiographic progression-free survival 5.8 months versus 3.5 months, hazard ratio 0.49, reflecting in a 51% reduction in the risk of death. If you look at imaging-based radiographic progression-free survival, it is at 12 months, 0.22 versus 0.13. So it is sustained. Definitely, there is a sustained response. But the most important criticism of this trial was that that the approval was for all the genes, where the actual benefit, magnitude of benefit was more for BRCA1, BRCA2, and ATM cohort. The second, physician's choice did not include chemotherapy. But there was approval of patients with HRR gene mutations in these 15 specified HRR genes for olaparib by the PROFOUND study. Next slide. Final overall survival, if you look at cohort A, BRCA1, BRCA2, and ATM mutations, median OS 19.1 months versus 14.7 months. If you look at patients alive at 1.5 years, 18 months, 54% versus 42%. If you look at the overall population, median OS 17.3 months versus 14 months. Hazard ratio 0.79. Approval was for all the HRR genes in this with olaparib. Next slide. Now, what about rucaparib, which is available at a substantially lesser cost in India? Rucaparib, the Triton 2 study was an international multi-center phase 2 study, open label. It included patients with CRPC, deleterious somatic or germline HRR gene alteration. Again, the list of genes is somewhat similar. Progressive disease on 1 or 2 AR-directed treatments. 1 prior line of taxane-based chemotherapy. So this included all the patients who were treated with taxanes. No PAR inhibitors or mitoxantrone, cyclophosphamide, or other chemotherapy, platinum-based chemotherapy prior was allowed. 115 patients we treated with rucaparib 600 milligram twice a day. And primary endpoints, cohort A, BRCA1 and BRCA2 only. So for olaparib, you have all these 15 genes being analyzed, cohort A and cohort B. Here in rucaparib, it's BRCA1 and BRCA2 only. So measurable disease, confirmed overall response rate as per RECIST was the primary endpoint. Without measurable disease, PSA response. Next slide, please. So if you look at this waterfall plot, you are having a significant overall response rate of 43.5%. Many are, so you are seeing ongoing responses. So O is ongoing responses. So many of these patients were having ongoing responses, and tumor and PSA response rates were consistent across subgroups defined by BRCA1 and BRCA2. Next slide, please. So after in this overall population, after 1 or 2 lines of next generation ADT, so patients treated with enza and abiraterone, and 1 taxane-based chemotherapy, confirmed PSA response rate 54.8%. Overall response rates were similar between BRCA1 and BRCA2, germline and somatic. So both germline and somatic were similar. So if you look at this table, if you had a BRCA1 mutation, overall response rate 33.3, BRCA2 45.3, germline alteration 42.9, somatic alteration 43.9. So overall a good response rate. And if you look at the radiographic progression-free survival in BRCA altered metastatic CRPC, 9 months was the median radiographic progression-free survival, and approval was given for BRCA mutated patients. So for olaparib, it is all those 15 genes. Here it is only BRCA1 and BRCA2. And secondly, in this, it was taxane-based chemotherapy should have been received. So there is a slight difference in the approval. Next slide, please. Phase 3 Triton study was also done, and there was a press release saying that Triton 3 met its primary endpoint of radiographic progression-free survival for rucaparib versus physician's choice. And in this, the physician's choice was again abiraterone enzalutamide, but this did include docetaxel also. Next slide, please. So what about the approval? In May 2020, olaparib is approved for HRR gene mutations, one of those 15 genes, progression on following prior treatment with enza or abiraterone, and rucaparib accelerated approval now confirmed in the Triton 3 also. Previous treatment with both AR-directed therapy and taxane-based therapy, and only for BRCA1 and BRCA2. Next slide. So selecting patients for PARP inhibitors, they are currently used for treatment with patients with adult metastatic CRPC, who have been treated with either androgen directed therapies and or taxane, especially for rucaparib. BRCA1, BRCA2 may be most sensitive, PALB2 somewhat sensitive, ATM may be insensitive. So even in the HRR genes, there are differential responses. Olaparib is for all HRR genes, rucaparib is for BRCA1, BRCA2, and prior chemotherapy exposed patients. What about sequencing? After AR-directed therapy, should we go for docetaxel or should we directly go for olaparib, especially if the patient is HRR gene mutant? And after chemo and AR-directed therapy, as of now, rucaparib has been approved. Monotherapy is the current indication, but now we'll be looking at some new data for PARP inhibitors in combination with other agents. Next slide. So these are all the studies which are looking at combining PARP inhibitors with various agents, and one of them with immunotherapy with pembrolizumab is negative. There are combination treatments with radium. There are combination treatments with lutetium, PSMA, anti-angiogenics like sedarinib. But the most important data which is coming up is for combination of PARP inhibitors and anti-androgen therapies, especially in the earlier line settings. So not prior treated patients of CRPC, in the first line setting of CRPC. Next slide. So rationale is, if you are giving, so this on the right side, you are having the doubling time of the tumors, and this is the control. If you are doing ADT, so that is castration, you are obviously inhibiting the doubling, reducing the doubling time, increasing the doubling time of the tumors. You are having PARP inhibitors, again, that is acting on killing the cells of the tumors. But if you combine these two, castration, ADT, and PARP inhibitor, you are having a higher, more doubling time of the tumors, and you are having a significant synergistic action. Why is that? Any ADT or a newer anti-androgen treatment like enzalutamide or abiraterone stimulates the DNA repair pathways. And if we inhibit the DNA repair pathways by PARP inhibitors, there is a synergistic action. And that is the rationale of combining PARP inhibitors and AR-directed treatments. Next slide, please. So phase 2 study, this was the first study which looked at all the patients. So this included patients which had either a plasma or an archival tissue tested for HRR mutations, but HRR mutations being present was not mandated. This was a phase 2 study combining abiraterone plus or with or without olaparib in CRPC setting, approximately 70 patients in each arm. And even though everyone was tested for HRR mutations, either on liquid biopsy or on tissue, it was not mandatory that everyone needs to have that. Next slide. What this showed was HRR mutation positive and HRR mutation wild type. So right top graph and the left lower graph both did have benefit with this combination. So in the HRR wild type, 15 months versus 9.7 months, and in HRR mutation positive, 17 months versus 16 months. And this was the rationale to conduct a bigger study using this combination. Next slide. So we have the results of the PROPEL trial, in which first line CRPC setting, ongoing ADT, docetaxel for metastatic hormone-sensitive prostate cancer is allowed. No prior abiraterone. No screening for HRR mutations is required, but optional biopsies, NGS could be done. Around 800 patients randomized to olaparib and abiraterone versus abiraterone alone. And the primary endpoint was radiographic progression-free survival. And this did meet its primary endpoint. Next slide. So even in patients without HRR mutations, you did have a benefit of olaparib in combination with abiraterone. So here you are seeing in the entire population, the median radiographic progression-free survival 24.8 months versus 16.6 months by the investigator, and by the blinded independent committee, 27 months versus 16 months. Hazard ratio around 0.6. Next slide. Magnitude was another study which used niraparib, not olaparib, and it used abiraterone again in the similar manner. The important thing is this used a slightly lower dose of niraparib, 200 milligram, and here you could have received abiraterone for around 4 months prior to being included in the trial. Again, the primary endpoint was radiographic progression-free survival. But the interesting thing in this is it was mandated that everyone should be screened by HRR mutation by either tissue or plasma-based assay. And there were two cohorts. One was HRR mutation positive, and the second was HRR mutation negative. And in the HRR mutation negative, there was an interim analysis which was performed. Next slide, please. After 200 patients, an interim analysis was performed, and there was a futility endpoint which defined futility as hazard ratio more than 1. And unfortunately, for patients who were wild type, this futility endpoint were met. There were higher grade 3-4 adverse event with niraparib, and the data monitoring committee recommended stopping the enrollment in HRR mutation negative cohort because of added toxicity and no added efficacy. One of the reasons might be because the niraparib dose was low. There are differences in the various PARP inhibitors also, but in this, there is no benefit across the board. In the propel, there is benefit across the board. Next slide, please. Primary endpoint in the HRR mutant cohort, 16.5 versus 13.7 months. In the BRCA1 and 2 mutated cohort, 16.6 months versus 10.9 months. Whatever benefit was seen in the HRR mutated patients in both BRCA and non-BRCA, but HRR mutation negative patient did not benefit, and the trial in that cohort was stopped. Next slide, please. We are having combination of PARP with enzalutamide also, with talazoparib and with rucaparib. So Caspar with rucaparib and Talapro with talazoparib. And talazoparib is positive. So it has met its primary endpoint of radiographic progression-free survival. So not only abiraterone, but also enzalutamide has been combined with PARP inhibitors in the first-line setting. And Talapro again is for all comers. It is not only for patients with HRR mutations. Next slide. Earlier disease may be a better target for AR and PARP inhibitor treatment because before, when the patient is having a hormone-sensitive disease or a non-metastatic CRPC, you could potentially have a better results. The patient has not received chemotherapy. Maybe the tolerance to PARP inhibitors is better because the side effects are essentially the same. Nausea, vomiting, anemia is a very important side effect. And prior chemotherapy also, because these patients are elderly, may diminish the tolerance of tolerability of treatment. So there are trials in the hormone sensitive setting, in the early phase setting, non-metastatic setting, non-metastatic CRP setting, which are looking at combination of anti-androgens with PARP inhibitors. Next slide, please. So questions remain: what is the best timing in relation to other life-prolonging therapies? What is the impact of these, or what is the impact on response of these agents after PARP inhibition? So, for example, you have lutetium PSA, you have PSMA, you have other chemotherapy drugs, you have cabazitaxel. What are the long-term adverse effects of PARP inhibition? And is therapy de-intensification an option in metastatic HSPC? So, can we use PARP plus anti-androgens before docetaxel, for example, down the line? Maybe these are the questions we need to answer. Next slide, please. I have come to the end. Thank you.
Thank you, Dr. Pai. Yes, very informative and good number of slides you have, and we got a good information from your slide. I would like to thank and appreciate on behalf of the entire audience. So I'll go for next presentations, and I would welcome Dr. Nandini Madam Ma'am. She is the speaker today on the topic of side effect of the androgen deprivation therapy, how to overcome it. Yes, very interesting topic she has been given, and I believe she will give a lot of information and share a good number of informations with us. So she is a medical oncologist, consultant medical oncologist, and practicing at TMH Mumbai. So I welcome again Dr. Nandini Menon. Thank you.
Okay. Thank you, Saurav. Can I share my screen?
Please, ma'am. You can share.
Is it visible? Okay. 1 second. Now what happened? What happened to my internet?
Dr. Nandini, you can stop it and reshare again.
Yeah, I 1 second, my computer is not. What is happening? God. Okay, now is it visible?
No, now you have to share again. You have stopped sharing. You have resumed. You
Again.
have to resume.
Okay, just 1 second. Just 1 second. I'm just
No problem.
something happened and my laptop was just hanging. Okay.
Yeah, we can see
Yeah.
your presentation now.
Okay, is it okay now?
Is it fine? It is fine. Thank you.
Yeah, thank you. Sorry for the glitch. Good evening, everyone. Today, the topic that has been allotted to me is side effects of androgen deprivation therapy and how to overcome these side effects. So quickly, without wasting any time, just an overview. We'll be discussing on the actual side effects of androgen deprivation therapy and why they are seen in some therapies. What are these side effects and how can we prevent or mitigate or manage these side effects once they occur? So we know that androgen deprivation therapy that we use traditionally for prostate cancer included the GnRH analogs and the antagonists, which basically decrease the testosterone levels and induced a castration state in patients with prostate cancer. The commonly used ones are leuprolide and goserelin. There are others like pamrevlin also that are used. So GnRH analogs, they stimulate the gonadotropin. Basically, they stimulate the pituitary to initially stimulate gonadotropin release, and because of pituitary hyperstimulation, ultimately the pituitary gland becomes refractory and there is inhibition of the pituitary gonadal axis and the testosterone drops. But there are other hormone androgen inhibitor therapies that are used in prostate cancers now with the newer agents, which include the androgen pathway inhibitors, where androgen synthesis is inhibited, like abiraterone, which inhibits the cytochrome enzymes needed for synthesis, and also the newer androgen receptor inhibitors, which inhibit the action of testosterone on various cells by blocking the androgen receptor. And these, in either as a single drug or in combination, can cause multiple side effects, which can have a significant impact on patients, not just on just in terms of quality of life, but also safety. And we need to watch for these side effects, take the precautions, and monitor patients closely while they are on this therapy. So we move on to what are the toxicities that we see when patients are on androgen deprivation therapy. So just like in breast cancer, where hormone therapy such as aromatase inhibitors or ovarian function suppression causes a hormone deprived state and which affects multiple systems in the body. Similarly, the suppression of the testosterone release or the inhibition of these androgen receptors and will also cause multi-system involvement. So the most common side effects that we see is one is on the metabolic parameters, which get deranged or worsened after use of androgen deprivation therapy, and also adverse effects on bone health. There is a potential cardiovascular harm that is seen. Thromboembolic events might be increased, and other symptoms that are commonly seen with patients where the hormones are being suppressed, such as vasomotor symptoms such as hot flashes, renal injury, fatigue, anemia, sexual dysfunction, and of course the impact on the mind and cognition and other body image issues because of testosterone deprivation. So this is the approximate frequency. So we know these are universal: hot flashes, almost 80%; muscle loss, very common. It's usually duration dependent. Weight gain is common, hair loss is common, emotional lability, fatigue, multiple reports in variable in different studies, definite association with depression, cognitive dysfunction, not well defined, but in population based studies have been reported. Up to 20% can have gynecomastia, 5 to 15% can have anemia, dyslipidemia, and definitely there is an increase in the incidence of diabetes and coronary vascular disease in these patients. And of course, these are some of the mitigatory actions or some of the precautions that we can take to tackle these toxicities, and we'll go through them one by one. So the first toxicity that I would like to discuss is the impact of androgen deprivation therapy on bone health. We know there are multiple studies on large populations, especially in patients receiving androgen deprivation therapy, where they have noted that there is a loss of bone mineral density in these patients. So ADT in males with prostate cancer increases the bone turnover, decreases the mineral density, and as a result of this can increase the risk of fractures. And in this, especially this cancer, which is very common in the older population, having a pathological fracture or a osteoporotic fracture can lead to significant other complications, compromise quality of life, and lead to multiple other issues. So as early as 6 to 9 months of use of androgen deprivation therapy, you can have loss of bone mineral density. And there are studies which have reported where longer therapy has increased the risk of bone mineral demineralization in these patients. You can see osteoporotic skeletal fractures in up to 20% of these patients. And of course, patients who have other risk factors for osteoporosis, such as poor intake of calcium, low vitamin D, use of steroids. And we must remember that part of our treatment paradigms, which we use for prostate cancer, especially in CRPC, we use a lot of corticosteroids. So these, and also alcohol abuse and smoking, can be contributory factors, and these must be tackled in these patients. So this is one of the papers which looked at GnRH agonists and fracture risks in patients who had non-metastatic cancer. And they looked at this in a large group of patients who basically were receiving Medicare beneficiaries. So they analyzed the data from these patients. It's an old paper, more than 15 years old. And at that time, they noted that using GnRH agonists not only increase the risk of any fracture, increase the risk of specifically hip and vertebral fractures, and the duration correlated with the severity or the increased risk. So there was a relative risk of 1.45 for vertebral and 1.3 for hip and femur fractures. And it was in the multivariate analysis, the treatment as well as the longer duration predicted the risk. This is again another similar paper which also showed that if patients were on short-term ADT versus long-term ADT, at the initial few years, that is in the initial 3 years, the bone-related events or the skeletal events because of osteoporosis was similar. But when you looked at longer follow-up, those who were receiving long-term ADT, they were more prone to having fractures, either pathological or non-pathological. So the question is now, if we have a patient who needs androgen deprivation therapy, which is the main treatment of the disease and it is the backbone, it may be in the form of GnRH agonists or antagonists, or in the form of orchiectomy. The medical castration that is we use predisposes to these more than the orchiectomy, but we need to understand that in prostate cancer, we are trying to suppress testosterone, and virtually all our patients who we are going to treat are going to be at risk for this. So what are the recommendations? There is a recommendation for the use of dual X-ray absorptiometry scan, X-rays, that is a DEXA scan at baseline. But some of the recommendations are not based on very strong evidence. Some of them are not very clear in whom we do it. NCCN and ASCO have given a recommendation that we should do this at baseline and identify patients who are at risk for fractures. There are also scores to look to predict patients who might be at an increased risk for fractures. And in these patients, certain interventions are recommended. However, despite all that, even in Western literature, less than 10% of patients who are starting ADT for localized prostate cancer underwent a baseline DEXA. So we probably may have even smaller number of patients who undergo routine DEXA scan. Repeat bone DEXA is usually recommended every 2 years or as clinically indicated as per these ASCO recommendations. So these were the ASCO guidelines, which again, the same points that have been mentioned before, that is advanced age, cigarette smoking, alcohol consumption, hypogonadism, steroid use, low body weight, prior history of fractures, which predispose patients. And this was their recommendation, that we use a risk assessment tool. And if we have patients whom we are starting androgen deprivation therapy or who are receiving androgen deprivation therapy, we must look for osteoporosis at baseline and repeat it when it's necessary, or at least every 2 years, and certain non-pharmacological interventions that can be used, such as exercise training, endurance training, and an adequate intake of calcium and D3, and of course stopping smoking cessation and limiting alcohol. So these were the non-pharmacological lifestyle modifications. Also, osteoclast inhibitors such as bisphosphonates and denosumab have been studied in the risk reduction in these patients, and all these guidelines recommend if these patients have a T-score of -2.5 or less in the femoral neck, hip, or lumbar spine, or there's a higher risk of fracture for hip fracture more than 3%, or for a major osteoporotic related fracture more than 20%. These patients can be started on osteoclast inhibitors such as denosumab or bisphosphonates. So these are the ESMO guidelines, similar, but for patients with scores of more than 2, they considered adding osteoclast inhibitors if they had these additional risk factors. So multiple studies have looked at the use of bisphosphonates, also looked at denosumab and exercise in tackling osteoporosis related to androgen deprivation therapy. This was a systematic review and meta-analysis which showed that there was a benefit, although these studies are quite heterogeneous in some respects, but there was a benefit with the use of bisphosphonates in these patients, as well as the various drugs they studied. And most commonly used bisphosphonate was zoledronic acid. And oral bisphosphonates also were studied in these group of patients, and they seem to be a benefit with them as well. Another side effect that has been noted with the prolonged use of androgen deprivation is increased risk for falls and fractures. The exact cause is not really clear, but there is a meta-analysis of 11 trials which this was seen with androgen receptor inhibitors, and they looked at a large number of patients in various trials who either received enzalutamide, apalutamide, darolutamide, or in combination with ADT or other combinations. And they looked at a control group who only received placebo with ADT or a bicalutamide or abiraterone and did not receive the newer second generation androgen receptor inhibitors. And they found that there was an increased risk of falls and fractures in patients who received these inhibitors, and they were more frequent with apalutamide. Exact reason for these falls being higher is not known. Possible explanations in the study, they said that probably the ability of these drugs to cross the blood-brain barrier might be a factor, and other factors such as fatigue, use of concomitant medicines, and other predisposing conditions in elderly people might be possible contributory factors to developing falls in these patients. So one of the recommendations is, although the risk is low, in patients who are at high risk for falls, we should identify them and take adequate precautions. So probably use of fall risk screening tools in these patients. So now we move beyond the bone and to the other toxicities. So vasomotor symptoms that are noted in patients who are receiving gonadotropin agonists, similar to what they get on tamoxifen, especially hot flashes, and they may affect the quality of life. It is not uncommon. It can be seen in up to 20% of patients. And if it starts affecting sleep, then it can have a significant impact. So just like in breast cancer, multiple drugs have been used, pharmacological approaches that have looked at SSRIs, SRIs, progesterone agents, cyproterone, and gabapentin. So this is one study which looked at patients with GnRH agonist use for at least 6 months, and the patients had hot flashes or or they asked for treatment for the hot flashes, or they had a minimum of 14 hot flashes per week. And in these patients, they were randomized to 3 arms, basically to receive a progesterone, that is medroxyprogesterone, cyproterone, or venlafaxine, which is a serotonin uptake inhibitor, and they assess symptoms. So out of these 3 drugs, medroxyprogesterone and cyproterone showed better results than venlafaxine, and they were more effective. Other drugs such as megestrol have also been used in patients with hot flashes, but there are reports that megestrol can cause rapid progression and so should be avoided in these patients. Gabapentin was evaluated in a phase 3 study where they looked at different doses of gabapentin versus a placebo, and 900 milligrams of gabapentin decreased the risk of hot flashes compared to placebo, with the frequency of the hot flashes decreasing, that is 46 versus 22%, and intensity also decreasing at 4 weeks. There are non-pharmacological approaches that have been tried in hot flashes, such as use of acupuncture, soy-related, soy-containing foods, or vitamin E, with varying benefits, which some have tried in these patients. Another very important change or very important toxicity or adverse events caused by androgen deprivation therapy or suppression of testosterone in these patients is change in the metabolism and the body composition. And this has long-term implications because the dyslipidemia and diabetes that is worsened or caused by these drugs can predispose the patient to cardiovascular disease and other complications. So there is evidence that the use of ADT decreases the lean muscle mass, increases the fat mass. Usually it's more the subacute fat. It also decreases insulin sensitivity by increasing, of course, insulin resistance by increasing the fat. And also there has been data to suggest that there is a statistically significant increase in newly diagnosed diabetes in patients who are receiving ADT over a period of time, and of course, definitely worsening of the pre-existing diabetes mellitus. And the alterations in the lipid profile is well known, where there is increase in LDL and triglycerides, and including newer forms of hormonal therapy, just such as androgen receptor pathway inhibitors like abiraterone, or our androgen receptor inhibitors like enzalutamide, epalutamide, also can cause these metabolic changes, including increasing risk of diabetes and dyslipidemia. And the way to mitigate these things is, of course, pre-starting these patients on ADT, we need to take a proper history, look for patients with pre-existing comorbidities, including dyslipidemia, diabetes mellitus, appropriate medical management of these issues during therapy, and regular monitoring of these lipid profile and the sugars, and aggressively managing these when they are worsened will help us to control and also maintain the patient and compliance with therapy. So that is an important factor to mitigate. It cannot be completely avoided. Many patients do get these toxicities and they need to be looked actively. We need to look out for these when we are prescribing patients with androgen deprivation therapy. Often patients, because they are on ADT, which are 3 monthly, and on oral drugs like abiraterone or enzalutamide, they do not come at very frequent intervals. They may be visiting at 2 to 3 monthly intervals, and it is important for us to have a schedule for follow-up in these patients, which incorporates screening for all these things or monitoring these in patients who have this at baseline. So cardiovascular risk, particularly ischemic heart disease and coronary artery disease, there is reports of increased toxicity in these patients, including those who are on androgen receptor antagonist and abiraterone. But there are conflicting results whether these drugs exactly increase the cardiovascular risk or not. There are two meta-analyses, one which reported that there is no increase in cardiovascular risk in patients receiving ADT, versus one which says that there was an increased risk. There are also studies which some suggestions that maybe GnRH antagonists may have a lower toxicity, but this has not been proven in whatever randomized data that we have, where there were use of GnRH agonists versus antagonists, and there is conflicting results. There is a pooled analysis from 6 phase 3 prospective randomized trials where they compared patients who received ADT versus those who received degarelix, and they said there was a 56% lower risk of cardiovascular disease. But this did not correlate with the other data that is available, including data for relugolix, where the data here, it was lower, 54% lower if you use relugolix as compared to GnRH agonists. But when they looked at patients who had pre-existing cardiovascular disease, there was a phase 3 study done, and they looked at major cardiac adverse events in whether they and compared them in those who received degrelix or leuprolide. And this study failed to show that degrelix was better and had a more favorable cardiovascular risk profile as compared to leuprolide. So we have conflicting data for this as well. But however, cardiovascular risk could be increased in these patients, and this has to be kept in mind. There is also increased risk of thromboembolism. We know that even when we have hormone therapy in women with breast cancer like tamoxifen, there is increased risk of thromboembolism. We may not completely be able to prevent them, but the suspicion and monitoring for these should be, we should have a vigilant for these events, especially on patients who are on long-term androgen deprivation therapy. So risk reduction strategies for patients who have metabolic changes or body mass changes, and how to mitigate these problems and prevent further complications is to actively reduce the risk, especially for cardiovascular disease. That is, look at patients who have baseline lipid abnormalities, hypertension, diabetes, and if they are, ensure that they are receiving appropriate therapy and being monitored. Statins may be used to lower the lipids, especially if LDL is high. Sugars have to be monitored. If the HbA1c or the fasting sugar is elevated, we need to treat, actively monitor and treat the patient. And there are recommendations that patients who have known cardiovascular disease and are going on to CBD should take aspirin unless there is any other contraindication. And most important include non-pharmacological measures which will go a long way, such as smoking cessation and also exercise in these patients. And there might be some patients, especially with pre-existing cardiovascular disease, diabetes, and other comorbidities, who might have other additional complications such as arrhythmias or other issues. And these patients might benefit from a referral to a cardio-oncology clinic where a cardiologist can assess and appropriately manage these patients in coordination with the treating medical oncologist. Another very common and often underestimated side effect of androgen deprivation therapy is fatigue. So it is highly prevalent. It significantly impacts the patient's quality of life, and it's quite a common side effect, though we don't often address it in our day-to-day practice, but patients do have fatigue. And there have been studies where up to 14% have developed a severe fatigue within a short time. Multiple strategies have been used, most commonly exercise training and aerobic and resistance training, which have been studied in patients, especially structured exercise training, which is tailored for the particular patient, and look and see how it improves fatigue in these subgroup of patients. So these are various studies that looked at metabolic syndrome and the various non-pharmacological and pharmacological measures that they used. This is for gynecomastia, and these are for fatigue, where aerobic and resistance exercises and dietary modifications were advised. And there were 2 studies which showed that these aerobic exercise and resistance exercises with diet modification decrease the incidence of fatigue as compared to the routine care. Anemia has also been noted, usually normocytic, normochromic. The relationship between the anemia and fatigue symptoms is not very clear. It doesn't always correlate. Some suggestions that it might be EPO responsive, but it is not recommended. So before going on to the other toxicities, the importance of structured exercises, and one of the ways we can tackle the adverse effects such as fatigue, risk of worsening of the metabolic parameters, a potential cardiovascular risk, is by helping these patients with exercise, which will improve the muscle mass, strength, cardiorespiratory fitness, and also help with patients with declining physical function. There is evidence for this. There is less robust evidence that exercise alone will improve bone loss, though it says that it has some benefit. Prevention of falls and fractures, completely the level of evidence is not as strong. And anxiety, depression, and sexual dysfunction, again in these parameters also there is less robust evidence for the role of structured exercise. However, structured exercise has a role in these patients, and especially in mitigating ADT related bone loss and improving the bone health. But again, here, like in the data for cardiovascular risk, it is inconsistent. There is data that says that it improves the bone health, but exercise alone may not be the only way that has that will improve the bone loss, but it definitely improves the bone mineral density for patients on ADT. So emotional and cognitive changes in patients who are on androgen deprivation therapy where testosterone levels are suppressed, there is definite data that there is an increased incidence of depression. There are some population-based studies where they look at the development of dementia, but the clear correlation or strong evidence has not been able to link the development of dementia with androgen deprivation therapy. But there is a potential that these drugs in the long-term use, especially as the population is elderly, has some association with some cognitive dysfunction. And there are recommendations from PSYOP that in these patients, if you are treating them and you are able to do an assessment, to probably do a cognitive assessment, at least by a mini mental status assessment. So we have an estimate, but the evidence for dementia is not as strong. So because of all the testosterone suppression, there are a lot of body image issues that can happen in these patients, because we know that testosterone deprivation leads to loss of muscle mass, weight gain, thinning of body hair, change in the testicular size because of the atrophy of the Leydig cells within the testis. Often because the androgens are so suppressed in these patients, and the endogenous estrogens within the patient, the ratio will be altered, and because of this you might have gynecomastia also seen in some patients with prostate cancer undergoing or receiving androgen deprivation therapy, especially if we are giving androgen deprivation agents alone without a second drug. So with this, I would like to conclude and thank the organizers for the opportunity.
Yes, Saurabh.
Yeah, thank you. So, Dr. Kamble, actually, it is already late. So, we'll directly go to our panel discussions with Dr. Amish Boda. Okay, we are already late, and we have taken some more time for some of few of the talks. So, anyway, so thank you, Dr. Nandini. And now I'll welcome Dr. Amish Boda, sir, to initiate the panel discussions. Thank you.
Thank you, Saurav. My slide is visible.
Yes, it is visible, sir.
Okay, so we have 4 panelists today. We have Dr. Ganesh Bakshi, Dr. Animesh Saha, Dr. Paulami Basu, and Dr. Sambit Nanda. Is that correct?
Yes.
Okay, perfect. So we have 1 surgeon, 1 radiation oncologist, and 2 medical oncologists. I think, we are running behind the schedule. I have some commitment at 9:30. So most probably we'll discuss 1 case, and probably we can reach some conclusion in the panel discussion. So the case is castration sensitive disease in metastatic prostate cancer. Dr. Ganesh, let me start from you. Dr. Ganesh, how do we define castration sensitive disease? We always say that castration resistant, there is a clear definition, but we never say.
We have definitions of resistance very clear. So we believe that initial diagnosis, when we have not manipulated the patient by any kind of hormone, where it will be either a de novo metastatic disease or a progression from some prior treatment, which would either surgery or radiation, and the metachronous metastasis would be a castration sensitive disease.
Right, Dr. Ganesh, but Dr. Paulami, if you have given ADT plus RT and in say high risk localized disease, and after 1 year of the treatment, patient has progressed, would you call it as a castration sensitive disease?
And the serum PSA is increasing trend, sir.
Serum PSA is 12. And the last dose of ADT is, say, 10 months back. Would you call it castration sensitive disease? It's very interesting because, we always talk of HRPC, we never talk of this. And there was one question in the Q&A also, where somebody said that, are there any patients of prostate cancer who ever present with CRPC upfront?
Okay. No, sir. Actually, if there is a gap is means 10 month, I think we may call it a castration sensitive.
We may call it as Dr. Animesh?
I'd probably like to check the testosterone level, but I think it's a gray area whether to call it sensitive or not, and there's no right or wrong answer.
So when the cells are still responding to hormone manipulation, they are castration sensitive probably.
No, Dr. Ganesh, but we'll have to give that hormone to understand first. I think what the definition of hormone sensitive disease says, de novo, it is very clear, as Dr. Ganesh said, that there is no hormone manipulation done so far. And in adjuvant setting, if there is a sufficient time elapsed after you have stopped ADT or any hormone manipulation, and the testosterone function has resumed, then if the patient develops metastasis, you call it as a castration sensitive disease. So this is something I found little interesting. Let's come to the case today. 55-year-old gentleman has all sorts of comorbidities, diabetes, hypertension. Patient had angioplasty 8 years back. He has been current smoker also. His only presenting complaint was painful micturition, and his GP thought of doing serum PSA and turned out to be 95.22 nanograms per ml. PSMA PET scan, both lobes of prostate, lymph nodes, fifth rib, L3 vertebra, and left esophagus. Biopsy, Gleason 9 adenocarcinoma. Patient came to me with PDL1 report of 35% and MSI stable. So, what is the diagnosis and the initial treatment? I think, Dr. Sambit, you have not spoken as yet.
Yeah, so we are dealing with a metastatic carcinoma prostate and presenting upfront with metastatic disease. There are 3 bony lesions, and we can see, and so it fits into the category of less than 5 bony metastasis lesions segment. So, given the fact that PSA is rise significantly, although there is one bad factor that lymph nodes are involved in this case, and Gleason score is 9. So, based on that, I just want to know that we have come to know about the bone metastasis based just only on the PSMA PET scan, or it is a PSMA along with the bone scan?
No, PSMA PET scan. I think, Dr. Sambit, you have touched the point which I wanted to highlight very well. I think you and I both heard Dr. Moses quite well, looks like that. What will be the initial treatment? Dr. Animesh, this is, according to Dr. Sambit, it is metastatic de novo HSPC, and we can categorize as the low volume disease. As per Dr. Sambit and as per what Dr. Moses told us, less than 5 or less than 4 bony disease, whichever way you want to look at. Dr. Animesh, what would you start in this patient? So let me give you options. Options, what we have is ADT with any of these second generation anti-androgens, that is called doublet, or we have ADT with docetaxel with either abiraterone or darolutamide, that is triplet, or we have ADT with EBRT to the primary tumor for low metastatic burden. That is where this patient qualifies for. I don't think ADT alone anybody would prefer here. So amongst these 3, Dr. Animesh, what would you start with?
Yeah, I think what was the age and performance of the patient?
55. Young guy, very active in social life and professional life both.
So I think after the triplet data has come up, I would prefer not to use androgen deprivation therapy and docetaxel alone. If the patient is not fit for triplet therapy, maybe we'll switch to androgen deprivation therapy plus enzalutamide or apalutamide or darolutamide. Having said that, as you have correctly pointed out, it's a low volume metastatic disease, and there should be a role of radiotherapy to the primary as well as to the metastatic site if they are radically treatable with SEVA.
So if you give radiotherapy to the primary and metastatic site, Dr. Animesh, then would you give triplet therapy or would you give doublet or would you just give ADT?
Doublet.
Doublet. Okay. Dr.
The
Sambit,
patient already has
radiation.
cardiac issues.
Yes, patient
Cardiac
already has
issues, diabetes.
patients 8
Right.
years back. Yes, Animesh, you wanted to make a point about cardiac.
I
Please
would
go ahead.
prefer to avoid abiraterone because of the cardiac issues and the need of steroids in a diabetic patient. So,
Absolutely right, Dr. Animesh, your point very well taken. Dr. Sambit, if this patient is sent to you to the by uro-oncologist or a urologist, and you have only 3 bony metastases, say 3 lymph nodes,
Yeah.
and you decide to give ADT with RT, would you give anything else apart from that?
First of all, I would like to say that this is not a very ideal candidate for giving ADT along with EBRT because of the fact that in all the 2 trials, the ADA trial and the STAMPEDE trial, they have used mostly node negative tumors with bone metastasis. Bone metastasis lesion was there, less than 5, less than 3, we may differ on that. Whenever there is a nodal involvement and depending upon the location of the node, if we are planning for EBRT, then we have to involve the whole of the prostate along with the node. That increases the toxicity, given the fact that the doses that they have used are like 55 gray in 20% or 36 gray in 6%. So this is not a very ideal candidate for going ahead with EBRT along with ADT.
Dr. Sambit, excellent. You know, you have hit the, again, you have read the trials very well. Dr. Paulami,
Yes, sir.
56-year-old, very active male with all comorbidities. But right now he is absolutely fit, performance status of 0 to 1 according to ECOG criteria. Lymph nodes are there, bones are there, and prostate is involved. PSA is 95. Gleason score is 9. Doublet or triplet?
Doublet therapy, sir, because I think abiraterone is not a very good option because there is a cardiac comorbidity is there. So ADT and darolutamide is an option
So
particular in this case.
here, if you see in this NCCN, ADT along with darolutamide is not an option.
Not,
If you want
yes,
to
sir.
give darolutamide, you will have to give
Along with
docetaxel.
docetaxel.
So
Yes,
what
sir.
would you choose, Dr. Paulami?
If Gleason score is 9, sir. So
Yes.
I think if PS is 1, then we go for ADT plus DOSI plus darolutamide because darolutamide has very limited toxicity. No CNS toxicity is there. So docetaxel is a good option. Even means liposomal means docetaxel. If a patient is diabetic, so we can avoid the pre-medication with steroid.
Okay. So you are for triplet. Animesh, if I understand
Yes.
correctly, is for doublet. Sambit will not take the option of ADT with EBRT because of the multiple lymph nodes involvement. I think, we are reaching some consensus. It is either between doublet or triplet. Okay. This is what Dr. Vijay Patil had already shown. Accrual of Peace 1 trial went on when there were new drugs were introduced and approved in the market. And if you see, there were a lot of amendments on the Peace 1 trial. So I think, there are a few questions which are raised. And Dr. Ganesh.
Yes.
Today morning, in fact, I had one patient. Patient stays 300 kilometers away from me. But this patient is 62 years old. He was little reluctant to tell me that whether he is sexually active or not. To orchiectomy or ADT?
So I think the libido is going to decrease with both, and the added treatment, if it is an ARI, it is going to go for a toss. So this basically goes on multiple patient factors probably. One is, as you said, compliance, distance, monthly, 3 monthly, 6 monthly ability to take and afford the injection. And finally, if we are going into it, antagonist versus agonist with a small advantage of cardiovascular diseases there.
See, orchiectomy also, see, none of these drugs, Dr. Ganesh, how many of cardiovascular events you have seen in your practice after orchiectomy?
I think since last 3-4 years, we have been actually probably looking in a good way at it. And we do take some prior investigations of 2D echo, ECG, lipid profile, and SOS refer to physician right from the beginning.
Okay.
Otherwise, because what happens is, very honestly, something like that happens, patient may not report to a surgeon.
Okay,
But
perfect.
I feel it may be happening like.
It may be happening. Okay, Dr. Animesh, which are the patients you prefer orchiectomy versus ADT? You see, these are the two trials which I have put. There are many. One which I put was 6 February 2023 on top. But there are many trials which say that orchiectomy versus ADT is almost the same. Okay. Dr. Animesh, which are the patients you prefer orchiectomy and which are the patients you prefer ADT?
So the patient where the compliance is an issue, coming back every monthly or 3 monthly for the injection, coming back for the follow-up is an issue, and affording the cost of every 3 monthly or monthly injections of ADT is an issue. I do offer both the option to the patient. I think this group of patients, by follow-up, compliance, and cost is an issue, I offer orchidectomy.
Orchiectomy.
Good.
Okay. Dr. Paulamy, Ganesh,
Sorry.
I'm coming to you. Dr. Ganesh, I'm coming to you. Just
Okay,
one.
I'll not say anything.
Dr. Paulamy,
Yes, sir.
ADT or
Uh,
orchiectomy?
ADT, sir. If it depends upon patient choice.
Depends on the patient choice. Dr. Ganesh, if I refer this patient to you, saying that के पेशेंट को मैंने दोनों समझाया, दोनों इक्वल है, पेशेंट बोल रहा है सर कौन झंझट करेगा इतने साल एडीटी लेने का, खत्म करो ऑर्किएक्टमी में. But when you look at this patient, the particular patient I'm talking, 56-year-old active guy, when I asked him about the sexual history, he said that he is sexually active.
Exactly.
We can look at intermittent ADT in this patient. Would you do orchiectomy just because we have sent you, or would you refer back this patient to us?
So the data of IID is slightly different in a metastatic setting. We can, I mean, it was a non-inferiority study.
Correct.
And the
Absolutely.
conclusion was not so clear. So it is still in favor of continuous androgen deprivation. So I would do an orchidectomy. Only thing is, if when you are repeatedly asking about orchidectomy, there are some obvious indications where orchidectomy is to be done. So if those indications are kept aside, then we have to offer a choice probably and ask impending neurological state and those things.
Right. So I offered this patient about intermittent ADT. I showed him the non-inferiority trial.
Right.
Also, I told orchiectomy. In fact, he preferred for intermittent ADT. He said, okay, sir, definitely not orchiectomy, because if my libido is going to be universally low, I will take my chances with intermittent ADT. This is the point which I wanted to highlight, because orchiectomy is not a bad option. Many times medical oncologists feel yaar surgeon ne to orchiectomy karke bhej diya, but I think that is also a good option in many of the patients, especially in India, where ADT can be cost cumbersome.
So one more small thing was with Dr. Amit Joshi, when I was associated, we used to counsel that way also, that the drugs sometimes in the combo, the doublet, triplet are expensive. So sometimes to vent out the cost for a certain group of people, we used to offer them orchidectomy.
Absolutely, absolutely correct, Dr.
They
Ganesh.
could buy the other better drugs to keep themselves well.
Correct. Yes, so right. And also, so many times I have seen that in the second and third recurrence, many a times patients stop taking ADT for some reason or the other. Who's treating them, what they are doing. Orchiectomy offers a one-time, chance of that. Okay. Dr. Paulami first and then Dr. Animesh Saha. Agonist or antagonist? Patient has refused
If
orchiectomy. Now you have to choose between agonist and antagonist.
if there is extensive meds, but in that particular case, I think there is a limited meds, less than 3, less than 5, right? Then I go for
So there are
generic
lymph nodes, there
agonist.
are 6 to 7 lymph nodes, and there are 3 bony metastasis. Gleason score is 9 and PSA is 95.
PSA is 95. Okay. If there is any, means spinal cord compression
There is no
or
spinal cord
extensive
compression.
disease, then I go for antagonist, sir.
So you will go right now for
Degarelix.
Degarelix because the oral is still,
Degarelix.
I don't think is available as of yet. Animesh?
Yeah, I think Paulami has rightly said. Only indication we use antagonist is when there is impending cord compression or bladder outflow obstruction or impending ureteric compression because of the mass or fat. In this situation, we use antagonist to avoid androgen surge. Otherwise, agonist will bring income.
So, and agonist with first generation anti-androgen, you avoid the surge. How many times do we see surge when we give first generation anti-androgens? Animesh. One of the most important point against antagonist is one every monthly you have to give. There is no 3 monthly, there is no 6 monthly depot. And second thing is long-term safety data. What Dr. Menon presented just before me is not available with antagonist so much. So, these are the two factors which sort of go against antagonist. But yes, you are right. There is no head-to-head comparison. And whatever meta-analysis they have said, both are equal. So it is the physician's choice, agonist or antagonist. Majority of the patient prefer, majority of the doctors prefer agonist. In this chart, though, I was seeing the debate. And this chart, people have said that majority of the patients you should offer Degarelix, and only LHRH
Just one
agonist.
point.
Yes, please.
Yeah, in this patient was having some urinary symptom, and the symptom may get aggravated by using agonist as compared to antagonist.
So, Dr. Sambit,
You have to wait at
agonist with flutamide or bicalutamide versus Degarelix without bicalutamide. What is it that you see? it is a difficult choice. My point of raising this point is there's still the I think there is no census that this is better. But yes, Dr. Animesh and Dr. Paulami, when we want a rapid reduction, I think Degarelix is the one which is the preferred choice. The only thing which goes against this is a monthly, which is there. Right.
Sir,
Yeah,
sir,
please,
if,
Dr. Paulami.
sir, if there is, means I think Degarelix means indication is one is spinal cord compression. If there is severe back pain or any neurological symptoms are there, and another is if there is any obstructive uropathy.
Okay.
Then we
because
prefer
here, if you
Degarelix.
use bicalutamide, you have to wait for at least 7 days before you give
Yes.
Right. Both of point well taken. But Dr. Paulami, I always urge people that we use very less spine surgeons in prostate and myelomas of the world. I think very important point is that we should use spine surgeons to stabilize the spine as and when required. The obstructive uropathy again is a very common thing. If you involve the uro-oncologist and they put the DJ stent, I think you have time with you. That is what I believe of that. Okay. Dr. Sambit, I had asked you that question and you had said, now this was one trial, one of the review, population-based North American. They said external beam radiotherapy in a low volume, apart from what you said about the lymph node, they have used the PSA cutoff of 10.
Yeah.
Would you practice that in your practice? PSA is 20 and there are 3 bony, no lymph node.
getting a PSA upfront metastatic disease, PSA less than 10 is very rare in our setting.
Absolutely correct.
And we do tend to practice that up to PSA 20 or 20,
Right.
20 25. We take up the patient for EBRT along with ADT. If the rest of the things are there, that there is no nodal involvement, bone metastases are there, but it has to be less than 5, and preferably some sites which can be salvageable.
Your Dr.
We don't
Sambit, you are
expect,
again
because of the
absolutely
fact
right. Please
that
go
in
ahead.
Western countries they see bone metastasis which are very small in lesion.
Correct.
But here
Absolutely
we
right.
see a bone metastasis where there is extensive spinal cord compression, there is a fracture, and we see a soft tissue component of 5 into 5 or 6 into 6 centimeter. Then that is not an ideal candidate for RT. But given the fact that in that case also initiation with ADT, and if we get some response, then addition of EBRT does help in overall management.
You are again absolutely right, Dr. Sambit. I feel I also take up to 20 PSA in a low volume bone only disease, because less than 10 hardly you ever see which is metastatic disease. You are absolutely right.
Yes.
So doublet or triplet is something which we had said. Again, Dr. Vijay Patil and I probably have used the same source of slides, look like. This is the trial 2:2 factorial design. If you see here, basically the disease burden, low is 43% and high is 57%. Okay, so it is not that piece one study was done only in high volume disease, it was in low volume disease also. Although 77% of the patients had Gleason score more than or equal to 8. This particular slide shows radiological progression-free survival and standard of care. By 2015, the piece one amendment was done, and the standard of care was ADT plus docetaxel, which was sort of compulsory for them to have a standard of care. 2.2 years versus 4.5 years. Now, this is something very good. And if you see the forest plot chart, again, low and high volume both benefited out of it. Okay, and this is the overall survival data of ADT, docetaxel, and abiraterone, 61 months, which is the highest reported OS so far in this. So, Dr. Ganesh, what is more important to you? Assuming that I say that we use triplet and overall survival doesn't change, but duration of HSBC doubles.
So it is a good thing, I think, because the moment we have a shorter time to CRPC or moment we enter CRPC stage, even probably the cells have become quite hormone refractory. The drugs, mostly in the CRPC studies, their duration or the benefits with each of the drugs is quite small. So I think each one is a good, but I still have one small reservation. We don't know when the triplet ends, what actually would work, who will be the patient, probably by the PS performance status wise, and what would be then. So we don't know this question.
So if the overall survival has improved, Dr. Ganesh, that means the second line and third line. If the overall survival is say 5.5 years, then the 4 years to 4.5 years you have HSPC. Remaining 1.5 years, patient have received something and they have benefited. My point was very simple. If you see this chart, the piece one, 4.5 years is with triplet, the PFS, that is progression before progression. For 4.5 years, people can continue doing their work. They can be in the normal life and they are almost asymptomatic. Dr. Animesh, are you still convinced with triplet in low and high volume both, or would you restrict only to low volume and fit patients, high volume and fit patients?
Yeah, I think a high volume and fit patient is definitely yes. And low volume, otherwise fit patient, I would definitely consider piece one protocol also.
Piece one protocol also. Dr. Paulami, as a medical oncologist, are you convinced with triplet?
Yes, sir. If it's a high volume disease, then I go for triplet.
No, if it is low volume.
When low volume.
There is a benefit in low volume also, right?
Correct. There is a benefit
Yes.
in low volume also.
Yes.
If you see this is a forest plot chart.
Yes. That's why triplet regime, sir.
That's why triplet regime. So
I have
low
a
volume.
small question. Should I
Yes,
ask?
Dr. Ganesh.
So the data also says when you see the side effect profile, I think that slide might come in a few slides in your also, but there are definitely the increase in side effects profile with the triple drugs than the control arm, probably. So how would you manage that? Would you sequence the triplet like the trial or the study, or you would do some modification or customization for your triplet to reduce that side effect profile?
So today, Dr. Ganesh, when you asked this question, I had given docetaxel to 3 of my patients. When the PEACE data came, they were already on ADT and abiraterone acetate.
Okay.
And I counseled them, all 3 of them agreed, and they received docetaxel. And this particular patient also is like that. He was first diagnosed in 2021. I counseled the patient 6 months down the line. But today, if you are going to follow PEACE 1, then you are supposed to follow the trial, this thing. So that is something there. To Dr. Paulami and Dr. Animesh, I think either of the treatment right now is correct because the world is divided. Majority of the ASCO guidelines and the NCCN guidelines, they still say that only in high volume you should use triplet. While there is other, they say that even in low volume you can use triplet. My take on this one is PEACE and ARASENS both are positive studies. You have abiraterone and you have darolutamide. Both have shown OS advantage. In a fit young patient, I don't think we should wait and we should give triplet with the double of PFS, which is there. Okay.
So, I'll just make one comment. So there is something called low volume disease, and there is also a term we are commonly used to listen that oligometastatic disease.
Correct.
Yeah. So low volume disease and oligometastatic disease might somewhere overlap if the volume is really low. And this group of patients, I think we should also consider for a radical approach rather than going for triplet. If all the metastatic side and the primary are radically treatable.
No, you're right, Animesh, but I think the selection of the patients there is very, very important because ultimately the prostate cancer, also like breast cancer, is a systemic disease, and you have to be very careful when you want to radiate all the metastatic site particularly. But I think Dr. Sambit had summarized that very well. We have only 1 minute, unfortunately. I'm sorry for that. I think Dr. Menon gave idea about, and Dr. Vijay Patil also gave the idea, depending on the side effect profile, you would choose one of the second generation anti-androgen. Wanted to just see what is the network. This is something which probably, I always get confused. Dr. Ganesh, HSPC mein, is there a role of Zoldria or denosumab?
So if I see a metastatic patient, I advise a bone mineral density, very honestly.
BMD is osteopenia. And say score is minus 1.9, not 2.1 ke upar.
then we minus T score above minus 2.5. We treat
No,
as
if it is not
osteopenia.
minus 2.5, it is not more than minus 2.5 and HSPC, do you give bone resorptive therapy?
No, we don't give, because a lot of extensive literature, unlike breast cancer, it has said that prostate cancer in the CSPC, it does not matter.
You are so right. I just wanted to highlight that point. Dr. Animesh, do you agree? Because I see rampant use of bone resorptive therapy in HSPC also. Prostate cancer, bone metastasis, matlab denosumab de do.
Yeah. So HSPC, sir, the principle of using the bone resorptive agent is different from using castrate-resistant prostate cancer.
Correct,
here,
absolutely.
We do not use for reducing the skeletal-related events or bone pain or etc. Here we use it for prevention of side effects from androgen deprivation. And the regimen is different. You use 6 monthly isoledronic acid or denosumab rather than using monthly what you use in castrate-resistant prostate cancer.
Dr. Animesh, so right, and thank you so much for that, because that is not something which is widely practiced, what I see. Dr. Animesh, is there a role of immunotherapy in this patient at this stage? PDL1 31%. Patient told me, sir, pembrolizumab I can afford. You want to add quadruplet also? I'm okay with that.
I think we have to wait for more mature data on IO before we can jump into it.
So you would not give. Dr. Polami, would you offer IO to this patient?
No, sir.
No. And I think Dr. Rohit Pai gave a very good lecture. So Dr. Polami, if this patient is say BRCA positive,
Yes.
where would you keep olaparib? Patient can afford. Would you? There is a data of olaparib with abiraterone and enzalutamide phase 2 data. Would you give now or would you wait for CRPC and only give then?
Actually, sir, I will wait, and if means I know there is data when we add olaparib, there is PFS benefit, but I will wait for metastatic CRPC and then I will add PARP inhibitor.
Then you will add PARP. Absolutely right. We don't have a mature IO data or mature PARP inhibitor data. We already crossed 30 minutes in this session, so I would conclude one case and we will not go to the second case. Our patient was, Ganesh, I have the last question for you. Our patient was started on ADT plus AA. Piece 1 data came in early 22. I shared with the patient. Patient took docetaxel, 6 cycles were given. Young age, tolerated extremely well. At 2.5 years down the line, patient is doing very well. GnRH analog plus abiraterone acetate. Patient's cardiac condition, according to cardiologist, was absolutely fine, and that's the reason I gave abiraterone acetate. Patient is asymptomatic, working for 10 hours, professional wildlife photographer. Dr. Ganesh, I just wanted to show you this thing. Have you started practicing or have you started sending patients to medical oncologist for this?
Yes, for NMCRPC.
Okay, Dr. Polami, Dr. Animesh, have you treated any patient which is non-metastatic, become castrate resistant?
Yes, sir. I have 2 patients on darolutamide.
And they have not in this particular scenario, right?
Non-metastatic CRPC.
Okay, perfect. Dr. Animesh?
So I think these are quite a rare group, and I have not yet come across in practice. But definitely, if they come, they'll be candidate for darolutamide or apalutamide.
Absolutely right. I think there's a very good difference. Dr. Ganesh, I'm sure you're convinced about this data. And the last comment from you before we close the panel, you wanted to say something, Dr. Ganesh.
So I actually met one of the co-investigators of Arasens.
Okay.
He told me a very different thing. You all are more expert in India in medical oncology. So I just took his comments and I heard that. It was quite good to hear. He said, when I use the Arasens in a triplet, so I would give ADT plus docetaxel. I would finish my 6 cycles of docetaxel, so as I don't have a toxicity of the third drug right from the beginning. And then I would start the darolutamide. So I would get something which is similar to a induction and a maintenance. And he really said he's doing that in Australia. And he's having a very good success with managing cancer control as well as side effect profile. I mean, this is
an expert opinion, Dr. Ganesh. Unfortunately, आज की तारीख में हम लोग ना डेटा के गुलाम हैं. Unfortunately,
I mean, his name was on the COI list of Arasens, and he's practicing that. And I just took it as it was a wonderful idea.
I think it's a very good practical tip, Dr. Ganesh. Thank you so much for sharing.
No, I should not share.
It's
I'm
okay.
a surgeon, but
you are just sharing. You are just sharing an expert opinion. To follow or not follow is up to the medical oncologist.
Seeing that side effect profile, even in piece 1, similar thing can be tried.
Absolutely right. Though in the new patient, I follow the trial protocol. But Dr. Ganesh, you are absolutely right in that. Let's take that home. Thank you so much with that. And I thank all the panelists about this particular case. And thank you so much for joining us.
Good night.
Thank you. Good night.
Thank you. That was a wonderful.
Thank you so much, Dr. Ganesh.
Wonderful discussion that we had.
Wonderful interactions.
Yeah.
Thank you.
So yes, Saurabh, over to you for the word of thanks, and please conclude.
Thank you very much, Dr. Amish Mohra, Dr. Bakshish, and other esteemed panelists and attendees. I know it is quite exhaustive in the weekend, and thank you very much to all of you for being with us. Today we have a good number of attendees again. It's almost 250 attendees we have attended today in the meeting. So thank you very much, and we'll continue such type of scientific activity and events in future also, and we're looking forward to your support also. Thank you very much again to all our esteemed faculties and panel members. Thank you. Good night.